Are there certain things, though, here in America, with our American food system and the increase in obesity, which as I understand it, hormones are kind of stored in all that excess body fat, is that part of the reason why it just seems like we're seeing more women presenting with breast cancer?
So I think that the obesity epidemic is absolutely contributing to a certain proportion of breast cancers being diagnosed. And we may see more increases over time if we don't get a handle on this. So our US population really needs to focus. Again, hard to target an individual, and not everybody who's heavy is going to get breast cancer. On the flip side, my clinic is full of thin people, and they look at me and say, I was doing everything right. So, you know, again, it's population-based, but still, you know, it's averages. But I think as a population, we need to be careful, and we need to start thinking more preventatively, not just about cancer, but heart disease and other ills that are associated with obesity and insulin insensitivity, because that's part of what is, you know, diabetes. Obesity can lead to type 2 diabetes, which we think all of that has to do with the development of certain cancers like colon cancer, breast cancer, and in men, prostate cancer. And so, you know, our whole society would do better for, you know, cutting down a little bit. Easier said than done, but we need to start thinking about it. And I think there are movements to do that. It's much harder.
I keep seeing, though, in all of the research now, insulin spiking, and inflammation, and also the effect that stress can have on the body in terms of inflammation. Is that possibly also contributing to this increase in cancer in this country? Because certainly we are a fast-paced, stressed-out bunch of people.
Yeah, so the stress, so definitely the obesity is contributing.
Out bunch of people.
Yeah, so the stress, so definitely the obesity is contributing. Definitely. We think there's the association, one of the mechanisms may be the insulin insensitivity. Stress is harder to measure, and the studies have been much less clear. Stress is it really stressful, or is it perceived stress? And one person may see a very busy day as an easy day, and one person may see that as the most stressful day they ever had. And so how you get a handle on that, you know, I think for anybody, we do know, for anybody who's survived breast cancer or who's living with metastatic disease, for women in that setting at least, we don't know that stress increases the chance of a cancer coming back or shortens a person's life. And so there was a lot of hype a decade or so ago that if you were stressed or if you didn't join a support group, somehow you were compromising your chances at survival. And those data have been debunked. And so, you know, women who don't want to join support groups, who don't get nurturing out of that, shouldn't feel that they're just serving themselves from a survival standpoint and force themselves to go to a support group if that's not their thing. That, you know, there was this whole kind of backlash where women felt guilty because they didn't do enough to control their stress. That should not be the case. What we want people to do, though, is to have a good life. We want people to exercise, take care of themselves. Those are the things that have been associated with people doing better after breast cancer. So people who are physically active and people who don't gain a lot of weight after a diagnosis of breast cancer, that's been associated with people doing better from a breast cancer survival standpoint as well as from an overall survival standpoint. So that's the key message. Take care, and those are also de-stressors. So if you're really stressed, it's hard to exercise, it's hard to eat right. And so if stress drives bad behaviors or not optimal behaviors, then yes, people need to lower their stress so that they can do the right thing for themselves and take care of themselves.
Well, this is your other area. It's interesting because your area of focus is really young people, and I can see why that drew you with all these special challenges we've been talking about. And then the fact that so many more women are living through and beyond breast cancer, which is the really good news here. But it also requires you to totally focus yourself on how now do we get these women to live not just healthy lives, but happy lives. So what are some of the issues? I mean, cognitive issues, emotion, mood changes. What are some of the things that we now know can be associated with the kind of, I guess I would say, after effects of treatment?
So we call these long-term or late effects. So long-term is they started during therapy and during the, you know, the diagnostic period, and they continue. Late is they weren't evident early on, but they can happen later. And so the long-term ones are the ones we think about a lot. So those are the side effects of medicines, which if you're on medicine for a long time can be long-term, like hot flashes, and some people feel achy on some of the medications for hormonal therapy. Some women, though, very early on and rarer longer, if they get chemotherapy in particular, and maybe from the hormone therapies, can feel cognitive changes, meaning difficulty multitasking. Chemobrain, or we call it oncobrain now. Because we think the hormones contribute, we think the stress contributes, we think the sleeplessness contributes, right? If you don't sleep well because you're having a hot flash, you're going to have a harder day and your memory's going to be a little tougher. The thing there is that women who have really report a hard time with multitasking. So the woman who could do it all can no longer do it all and has to kind of take her time and do one thing at a time and make lists where she used to kind of be able to rattle off her head. And that's a real loss for people.
And that's common?
It's very common.
Oh, I'm so glad to hear that.
Yeah, it's very common.
I hear it from everybody.
Yep, I hear it from patients all the time.
Even young ones, even some of the young women.
Well, they're probably trying to do the most. That's
well,
one
yeah,
of the
and they
issues
say
there.
all of a sudden they go upstairs and say, "What did I come up here for?"
Yeah.
I said, "I'm so glad to hear that you're having that problem and you're only 27."
Yeah. Well, I always say to my patients, though, as their non-breast cancer control, that happens to me all the time too, because I'm doing too much.
Okay.
We have to be careful as we measure these things, how much is due to just busy life and add on a breast cancer diagnosis, and how much is actually due to the drugs or due to something that we could modify. We can't say, "Oh, I wish you hadn't gotten breast cancer." I mean, we can say that, but we can't prevent that without a lot of other work. But we can say, oh, do these drugs cause more cognitive dysfunction than these? And how can we modify treatments? As our treatments get better, that may be one reason not to do something if you knew it was something that drove these kinds of changes more. So that's what we try and do the research to figure out. But right now, the cognitive dysfunction thing is really, it's mixed up because we know that chemo contributes. We've seen that pretty substantially. The good news is most people get better over the next couple of years.
It wanes?
Yep. And people can do, if it's profound, they can actually do cognitive rehab, kind of like physical rehab, but they can go to a specialist in brain rehab. And they use this also for people who've had brain injuries to help them get back on task. Most people will do crossword puzzles and make lists and try and just kind of shore up the vulnerability.
Help?
Those things can absolutely help, help a person keep things in line, and also, it's kind of use it or lose it too. This is true for as people age. You want to keep them busy, nimble, and using it. But it can be a real challenge, especially for a busy executive or a busy mother who's trying to juggle a lot of activities for a child or children. So cognitive dysfunction is big. The other big things we just talked about the health behavior. So many women unfortunately gain weight during therapy. And we don't think that's because people are putting that much food in their mouths. We think that it's more because they're less active.
And they're nauseous.
And they're nauseated, and so they're eating comfort foods. So I encourage my patients to be physically active through treatment when they can. I don't want to beat them up, but I don't want them to say, "Oh, I've got breast cancer, I can't exercise for this time." And it's hard to exercise. It's hard for anybody, even without cancer, to exercise and get kind of through that energy of activation. So I tell patients, I'll write them a prescription sometimes saying, just take a 15, 20, 30-minute walk.
That's
whatever
awesome.
You can fit. Yeah, because people are busy, especially the young one. They're like, "I don't have time, I don't have a babysitter, my husband gets home." I say, you know what, if I wrote you a prescription and you said to your husband, "I need that half hour," I'll bet he'd say, "Oh yeah, I don't want you to gain 20 pounds either. You'll be miserable. And that's bad for your overall health, and that's bad for your breast cancer health. And you don't want to have to, it's much easier to prevent it than to put it on and have to take it off." So that's a big deal, and that's a long-term effect that can happen. And there are so many others that I could rattle off, but that's in survivorship, that's what we focus on. And we also focus on the coordination of care. So when a woman gets diagnosed with breast cancer, she's kind of in the oncology realm.
Yeah. You're like shot out of a cannon.
Yeah, and you might see your primary at some point again, and then you develop this bond with your oncologist or your surgeon, depending on the treatments you received and the people, and they need to get back into their regular doctor because we don't want to neglect the flu shots, the colonoscopy if you had breast cancer. You don't want to forget about the other cancer risks, the lipids. If someone has high cholesterol, they need to be continuing to follow, or they're at risk for that. And there are numerous other reasons that the primary still needs to be back involved. So we're working on systems to communicate well with the primary so they know what happened to the patient, and so the patient knows what happened to her, and so the doctor can feel comfortable taking care of this patient who's been through something that usually your average primary care doctor doesn't know as much about.
Yeah,
so
that's
there's
really
lots
important
of coordination
important
needs
advice.
to happen.
Just a general question, how optimistic are you that we're going to see a cure in the near future?
So I think we're already seeing cures in some cancers for obviously certain patients, and I think we're chipping away. And so, my near-term optimism is more and more treatments that make it a chronic disease for subgroups. So
You'll get through it,
you'll get through it, and maybe you'll be on maintenance therapy. Maybe you'll be at risk, but it'll be so far out that we'll deal with that. And then maybe once, if it happened again, it came back, we'll get it under control. And we're seeing that with HER2-positive disease already. So it used to be when people were diagnosed with HER2-positive disease, they might live a year or two, and it was really ugly and horrible for that patient and the family and for their doctor taking care of them. And now we're seeing people live 5 years, meaning with metastatic spread disease, 5 years. I've got a number of patients in my practice who have gone 10 years and beyond, which was unheard of years ago. And that's due to targeted therapies and us getting smarter. And we've always seen that with hormone-sensitive disease, and now we're even getting smarter with that. So I'm hoping we're going to see more and more lengthening of time that people live with the disease when they've had it come back. And of course, our adjuvant therapies, meaning the treatments we give to try and blow it out of the water and get rid of it, we're getting smarter about. And we're giving less toxic therapies when we can.
Yeah, so that we don't have to deal with all those after effects.
Yeah, so if you don't need chemotherapy, let's not do it. Yeah. And trying to tease out who needs chemotherapy. We've got some smart tests to figure out better who really is going to benefit from chemotherapy and who's not, and who can we spare. Same thing with our surgeries. We used to take all of the lymph nodes from patients. Now we only take a sampling, and then if we see some, we might take the rest, but if we don't see some you can spare it, and that spares the swelling of the arm and the lymphedema and things people are at risk for. So I think the tailoring of the therapy is helping a lot of women to not have long-term effects, and then the targeting of the therapy is helping more women to live longer and more women to not hear from it again when they have early stage disease.
And might we, like in cervical cancer, we found now we have a vaccine, might we someday have a vaccine that will prevent breast cancer?
So, if you'd asked me this 5 years ago, I would have said, yeah, that's far off. I'm optimistic because there's a lot of research to be done. There has been a tremendous change in the last couple of years in terms of immunotherapy and some real breakthroughs that have been made. And immunotherapy collectively is kind of harnessing our own internal surveillance system, our immune system, to see cancers as foreign and attack them. But of course you have to be careful with that because cancers come from us. And so attacking a cancer can also cause autoimmune diseases or problems that attack our cells, good cells. And so finding that right balance, and there's been huge breakthroughs in what we've termed taking the brakes off the immune system, just a little bit, and saying, okay, if we take the brakes off through molecular mechanisms and smart drugs, can the immune system now recognize something on the cancer cell that also won't be recognized on other normal cells, or at least too many, so there's not too many side effects, and attack that cancer cell and control it or get rid of it? And just in the last couple of years, huge breakthroughs. Breast cancer, not quite yet. There's lots of research, but in melanoma, huge differences. Kidney cancer, we're seeing huge differences. So it's very exciting. Lots of promise for breast cancer, too.
One last question. Mastectomy, lumpectomy. Are we seeing too many women do mastectomies? I mean, I know it's, nobody even knew what BRCA1 was before Angelina Jolie, but on the other side of the coin, this idea of like just take them off and then the problem's gone, when maybe it's not gone. Maybe something already traveled to somewhere else before you took them off.
Right.
Is that a concern that we have to kind of harness that a little?
So it's a big concern. And, thanks to Angelina Jolie, because I do think more awareness of family history and genetics is really important. It's what you do with it, right? Knowledge is power, but you got to manage it. And so, I'm glad that she's highlighted this issue. I'm glad that women with strong family histories or who've had breast cancer at a young age are more likely to be tested, likely because of her advocacy. On the flip side, we're seeing more and more women who don't have a family history, who don't have a genetic predisposition. And for those women, there's no value medically in taking the other breast off if they're diagnosed with breast cancer in one breast, or at least limited value and clearly no survival advantage based on what we've seen. And so women are taking the other side off. Most of the literature, including some of ours, suggests for quote unquote peace of mind and for the goal of get it over with, I never want to deal with this again. And there's some faulty logic there, unfortunately. And there's also, you worry that a woman who does that may say, I'm done with it, and she may be less rigorous and vigilant with taking her tamoxifen, which is proven to cut risk in half and improve survival, for example.
Yeah.
So I try and counsel people, it's a very personal decision, and there are other reasons to take a breast off. There are other reasons, symmetry, cosmetic. Some women are truly traumatized by undergoing a mammogram again if they've had a cancer in one breast. And women are feeling vulnerable, and they're feeling like they can't trust a lot, right? The bullseye was on their back, and they don't want to be that again. And so we use both the numbers and say, well, the risk of you getting a cancer again is really small for a new cancer. Your bigger risk is this cancer coming back. Let's focus on that. And we're successful with many women, but for some women, it's just they can't reconcile it. And so we support them because, if it's going to make them feel better emotionally, usually we support them to do it, and then there are other reasons to do it. But it's tricky, and we're seeing some backlash. Some insurances are saying, look, it's not medically necessary. I don't know if it makes sense. And that's kind of with good reason. I don't like insurance companies to be making the decision. I like to make the decision with my patient as the provider. That being said,
it deserves discussion.
It deserves discussion, and every woman needs to really think critically about the true value of it.
Well, I thank you for this discussion.
Thank you for doing it.